Good evening, all. So we'll discuss one of the important aspect, that is how to approach to DRNB critical care medicine practical examination. We know that this is the toughest part in the exit exam, because you have to give lots of in terms of to satisfy the criteria to pass this 3-year program, that is DRNB critical care medicine. You need to go through long cases, short cases, and table viva. Also the different stations, particularly ECG, imaging, ABG, ACLS, ATLS. So along with that of hemodynamic monitoring, ventilator graphics. So lots of things you need to concentrate in a single day. So you should be able to answer the questions thoroughly to have a fruitful outcome, that is passing of your DRNB critical care medicine examination. So basically, one thing you need to remember after you finish your theory exam. So there is lots of time gap is going to be there when you appear for practical exam. So during that time, one thing I strongly want to advise is you should not forget anything, whatever you written or whatever you read and practice it for your theory exam. So that is very, very important. You need to carry forward that examination, means knowledge for your practical exam also. So we know that DRNB practicals, like other any of the practical exam, it's going to be a nightmare. Don't worry, if you have a good protocolized systematic preparation for practical exam, so then you can have a good result without any problem at all. So if you see the national board examination pattern, so it gives some rules and regulation for practical examination. So it's going to have a 300 maximum marks. It comprises both OSCE and our clinical examination, and also it include viva. So candidate must obtain a minimum of 150 out of 300 marks to qualify for practical examination. So there are no grace marks in practical examination. So there are a maximum of 2 attempts so can be availed by a candidate for practical examination after theory. So first attempt is the practical examination following immediately after declaration of the theory result. So that is being considered as your first attempt. So the second attempt shall be permitted out of the next 2 sessions of DRNB final examination. So you can give 2 attempts maximum after your theory examination result has been declared. Remember, so absentation from practical after successful submission of application is counted as your first attempt, as your one attempt. So that's why you have to be very sure. So you need to attend the exam. So after you submitting your application successfully, so appearance in first practical examination is compulsory. Okay. So requests for change of center or date of examination is not entertained and not permissible. So candidates are required not to canvass with NBEMS for the same. Means, so there is no question of changing the date or the center at any cost. It doesn't mean you approach to NBE, they are not going to entertain at all. So whose thesis, that is dissertation, are not accepted by the time of announcement of practical examination. So practical examination center shall not be allowed to appear in the practical examination. So thesis completion and its acceptance from the National Board of Examination is very mandatory for giving a practical examination. So National Board reserves its right to make amendment to the scheme of practical examination with a prior intimation to the applicant candidate. So these are some of the basic rules and regulation you should be aware when you are taking a practical examination of critical care medicine. So this is the pattern. If you see, so maximum of 300 marks will be there. So there are clinical examination, that is a clinical case discussion. So there are 2 long cases, so 50 marks each. Okay, so you need to score like appropriate marks to get your 150 marks out of 300 total marks. Okay, so they will write the marks obtained and the total marks obtained among all the cases. So short cases you will have 2, so 25 mark each. So they are going to give like 30 minutes for each long case and 15 minutes for each short case. So discussion is going to be around 30 minutes for each long case and 15 minutes for the short case. Okay. So short cases should focus on single organ system, like examine the cardiovascular system, respiratory, neuro, etc. So long case, like it will go through the entire system from A to Z. So don't forget on that. So when it comes to station, it's going to have a maximum marks of 90. Okay, like 5 stations. So one is X-ray, CT, lab investigation, 20 marks, and like drugs and instruments, 15 marks. So ECG, ACLS, hemodynamic monitoring, 20 marks. Airway and mechanical ventilation with ABG, it's going to be 20 marks. Ultrasound and echo for 15 marks. Then you have a last part of examination, that is Viva post examination, which include around 60 marks. So that will have division like this: current literature review, 15 marks. So evaluation of research paper, so its clinical relevance, so comments on hypothesis, methodology, results, etc., that is 15 marks. So communication, legal and ethical aspect, so 15 marks. So clinical audit, patient safety and quality indicators in ICU, that is 15 marks. So time allotted for each viva is going to be 15 minutes. So each station time allocation is going to be 15 minutes. So later, so they are going to club together the clinical examination marks, so station marks with that of the viva was examination to get a final mark, total marks out of 300. So then they will give a pass or fail. So remember, examiner has to put the reason why they are failing a particular candidate. That's why, so it's not a very easy task to just fail any particular candidate unless otherwise they have not put effort at all. So because the examiner has to put rationality, reasoning why they are failing a particular candidate in practical examination. So don't worry. So put the things in a protocolized in a systematic way. So what all to read? So cases, all the cases which you go through in the 3 years of critical care medicine, you need to be thorough on that. So all the notes you have written for theory. So this is again, I'm reinforcing. See, practical examination need your theoretical rationality, theoretical concept. So without theory knowledge, you can't pass the practical examination at all, because many questions, they might ask you evidence, okay, they might ask you the pathophysiology, etiology, your management, differential diagnosis, okay, that needs the theoretical backup. So clinical examination, this is very, very important. See, some examiners who are from a pulmonology or a critical care medicine background, they might like expect you to examine the patient individual system. They might ask about cardiovascular examination, neurological examination, including cranial nerve examination. Okay, they might ask like motor, sensory system, power assessment, and all those things. There is no way like you are going to attend the exam. But the problem is, so whether you need to read entire things of the clinical examination of Hutchinson's or any sort of like book like Kundu and all. So no need. But the thing is, basic clinical examination you should be aware. Okay, so there is no escape for that. So all the topics covered in departmental presentation, that is very important. So during your 3 years, whatever the cases you presented, whatever the cases you discussed, that should be thoroughly recalled before practical examination. So no way you are going to clear if you don't know ACLS, BLS, and ATLS. ECG, you should be aware beyond like atrial fibrillation, okay, beyond ventricular tachycardia, ventricular fibrillation. So ventilator graphics, very important. Statistics, okay. So basics of statistics means like how you can like calculate the sample size, what is the significance of p-value, bias, okay. So importance of crossover, intention to treat, okay. So like what are the limitations of statistical analysis, all those things you should be able to tell when they are going to assess your critical appraisal of the paper. So again, communication in ICU, so ethical principle, end of life care, incident reporting, critical incident reporting. So quality indicators in ICU, auditing. So what exactly the auditing cycle? So they are going to means ask any questions whether you have done any observational study or auditing other than your like thesis. So in your practical examination. So end of life care. So it's ethical principle. Okay, they will give a scenario in one of the table viva. So, and they are going to ask questions in and around how you are going to break the bad news, okay, how you are going to give some sort of explanation, when a patient relative asks in relation to end of life care and all, with the background of ethical principle. So in short, read everything in critical care medicine, no escape for that. So it's a well structured examination. So in one day, so they are going to assess all the necessary competencies in critical care medicine. So broad questions, but not deep. So there are two ways of asking the questions. See, some questions are broad. Okay. So enumerate maybe like pathophysiology of the ARDS. That's it. So when you fumble, they might go in depth into those concepts. Means they might ask in the next question. So what are the different phenotypes of ARDS? What are the differences between primary or secondary ARDS, or like pulmonary or extrapulmonary ARDS? What are the different etiology? What are the newer theories they proposed on the etiopathogenesis of the ARDS? All these things, they might go in depth. So there is no end for it. So if you answer confidently, like the broader questions, they might go to next question. If you fumble, definitely they might go into so in-depth assessment of the knowledge on that particular concept. So move on to long case. Okay, so it's going to involve multi-system. So it may start with pneumonia. So maybe patient will develop a shock. Okay, multi-organ dysfunction. So he might had a some sort of tube block. So cardiac arrest. So hypoxic ischemic encephalopathy, end of life care. So it may move anywhere when it comes to long case. So they will give 30 minutes. Okay, is it enough is a question, but there is no question on that. So you need to finish taking the case within 30 minutes. So 30 minutes will be allocated for discussing that particular long case. Okay. So it is very important to follow some format. So generally examiners will assess your systematic approach. See, whatever the format, whatever the way you take a case, so examiner will see whether you are putting the things in a systematic way or not. So opening statement, you can start with, okay, age, sex, so days in the ICU, diagnosis, reason for ICU admission, whether he came for respiratory distress, unstable hemodynamics, or malignant arrhythmia or post-cardiac arrest, so that you need to mention. So any current issues can mention that you will expound on this later. Okay, so history of the presenting complaint with a relevant past history. Sometimes see, some past history may not be relevant at all. So he underwent so appendicectomy 25 years back. It doesn't mean for a critically ill patient and critical care physician. So issues that occurred during ICU stay in a chronological order. So earlier events to current events. See, patient admitted with respiratory distress, and later you tried with a high flow nasal cannula or NIV, he got tubed. So while tubing, he had a bradycardia, arrest, or he had a pneumothorax post-intubation. So you need to put the things in a chronological order. That is very, very important. So summarize your history with the key events. When it comes to examination, I told, so there is no limit for it. Okay, so some examiners, if they are from a critical care background, so they might not too much bother on a medicine examination. But if a specialty background is medicine or pulmonology, they might ask you to demonstrate the examination, and also you need to prepare for it. So start with appearance. So don't forget about lines, tubes. So what position is the endotracheal tube is being like connected and fixed? So nasogastric tube fixation. So infusion, whether a patient is on diuretic infusion, dopamine, dobutamine, okay, in a cardiac ICU, or norepinephrine, milrinone, all those things, you need to know with the dosage what they are giving, because different institute follow different dosage. But it is your duty. You should know from a nursing staff what is the dilution they used and what is the dosage they are giving. So equipments around the bed. So what monitoring, whether patient is attached to CRRT machine, okay, so what mode of ventilation settings, other devices, whether is being connected to any sort of advanced hemodynamic monitoring, ICP monitoring, so all those things you should be aware. When it comes to neuro examination, so mention what analgesic sedation is on, whether it is on high dose of fentanyl with propofol or dexmedetomidine, you should be aware. So is he on any anti-epileptics? Okay, so the patient is as was on note when sedation is stopped, means when was the sedation stopped, so what sedation the patient was on, that is also very, very important. So would like to know when sedation or analgesia was stopped, especially in the situation where the patient is not waking up or if a patient is extremely delirious. So don't forget to mention about the GCS. So pupil corneal reflexes, particularly in the post cardiac arrest scenario, cough and gag reflex. If you are like assessing for the weaning, extubation, or if a patient is brain dead. So limb movement, power, plantar reflex. So some examiner will expect all these things when you get a neuro case or any metabolic encephalopathy or encephalopathy patient. So cardiovascular system. So what vasoactive therapy is the patient on? So that is very essential. Okay. Peripheries, you need to comment whether any mottling is there. So peripheries are cold or not, capillary refill time, so mean arterial pressure, heart rate. So heart examination, including heart sound, any obvious murmurs you need to comment. So cardiac function, like if possible, if you have a facility of the ultrasound, so they might ask you about the ejection fraction, means the eyeballing of contractility and IVC. Okay, they might ask you to comment lung ultrasound, B lines. So E fast, all those things they might ask if it is a trauma background. So that you should be able to demonstrate if a examiner asks. So ECG, you should go through if they have done and if they are attached in the file. So respiratory system. So as I told, position, what they have fixed for the endotracheal tube. So details on intubation grading, Carmax and Lehane grading. Okay. Or if the patient was a difficult airway, you should have that idea. So when you are assessing and your viva goes towards so weaning difficulties and all. Okay. So because if you don't aware about like some sort of difficulty in intubation or mask ventilation, so then you can't complete your assessment for the weaning at all. So that idea you should be having when you present the case to an examiner. So not too much focus on history or negative history. So some examiner, as I told, if it is very much irrelevant, so no need to focus too much on that. It's going to kill your time. So just patient came with a fever, myalgia for 5 days, so developed breathlessness, intubated, developed acute kidney injury, underwent continuous renal replacement therapy. So initial labs showed thrombocytopenia, now day 5 in ICU. So this is how you can summarize. So whatever the events in a chronological order. So next examiner will start with a differential diagnosis and they will tell to go on. So some did not bother about examination at all. As I told, it's very difficult to predict any particular examiner. So that's why better to prepare with the basic examination on a system basis. So some did and even asked to demonstrate superficial and deep palpation of the abdomen. Okay, they might ask you to show the percussion, neurological examination, particularly in a systematic way. So that's why it is better always to prepare. So when it comes to examination, so don't forget to note down the following examination findings in the limited time which they given. So tubes, lines, okay, whether patient is having any particular drain, fictile, so catheter including dialysis catheter, Foley's, okay, suprapubic catheterization, number of days, what size they used, nasogastric or nasojejunal, or is the patient on like oral feeding. So what all infusion is going on, what all drugs giving in terms of the antibiotic, their dilution, duration of infusion, dosage, okay, frequency. If patient is on CRRT, when was the last CRRT stopped? Okay, what was the prescription? What was the dialysate dosage? What was the blood flow they used, effluent dosage, what dialysate they given, whether it's heparin free or they used citrate anticoagulation. So CRRT prescription, you should be aware. So monitoring alarm settings, okay. So ventilator and its alarm settings, cuff pressure, endotracheal tube cuff pressure, arterial line, when it was zeroed. If a patient is on PA catheter, you should be aware when it was zeroed, including ICP monitoring or central venous pressure monitoring. So labs, biochemistry, ABG, and the imaging. So when was the CT done? When was the MRI done? Whether ultrasound done, fast examination done or not, any angio done, okay, including the DSA, digital subtraction angio, MR angio. So all those things you should be aware. So there is no escape. So you might stuck at any part during your demonstration of the examination skills. So if you put all these things, it covers everything, like what you should be aware. So fast in bed, please, like analgesia, whether patient is on any antiemetics, okay. So adverse drug events, so sedation, spontaneous breathing trial, when it was given thromboprophylaxis, so if needed tetanus prophylaxis, particularly snake bite, so pregnant patient, or if a patient is a post-trauma, head up position is given or not, if not given, any valid reason like any patient is having cervical spine injury. So like stress ulcer prophylaxis, glycemic control, if the patient is on insulin, what was targeted in terms of the glycemic control, skin, eye care, so suctioning done or not, indwelling catheter, nasogastric tube, bowel care, when he passes motion, whether he's having constipation, loose motion, so C. diff infection, so temperature control, appropriate surroundings in delirium, particularly they adopted any delirium management protocol in that particular patient. So whenever the antibiotic de-escalated, okay, so whether used any diuretic for the de-resuscitation, so psychosocial support, any needed, particularly for a patient with a toxin ingestion background, whether any sort of psychosocial support has been given or not. All these things are very important when you take on the history and that of the examination part. So regarding ultrasound during examination, see, if you ask, they might give, okay, so but make an habit, so you can ask, okay, can I get a echocardiography machine or an ultrasound machine? So if time permit, you can do it, okay. So examiners, sometimes they are not bothered because you have a one station on the ultrasound in the afternoon. So but some may want it to be done, so better ask for it. If they say no need, then it's okay. So but make an habit, so can I use the ultrasound? So 30 minutes means 30 minutes. Whatever you want to put, everything need to be put within that 30 minutes of long case history taking with the examination and all. So you can scribble down whatever in the answer sheet. Don't go in-depth writing, but don't miss any important finding when you are making a note while examining and taking a history of a long case. So don't expect to write in a detailed manner. So just scribble down important. So what you feel, okay, these are important highlights while presenting that particular case. So this part is very, very important. So when you are ready with taking and finishing the long case, so before presenting, so classify your thought process, okay. So there are some aspect which you can consider general aspect in any particular case. See, so intubation, airway, so how you intubated the patient in terms of the nutrition management, hemodynamic monitoring, okay, fluid therapy, sedation, pain, delirium assessment, infection control policies, weaning, end of life care. See, these are like common for any particular patient, whether you get a pneumonia, whether you get a sepsis, whether you get GB syndrome, okay, myasthenia gravis, or trauma. So all these things are a general aspect. You should have idea, okay, what you are going to tell in that particular patient in this subheading of general aspect. Next is the specific aspect, okay. This patient need a steroid or not, COPD, asthma, okay. So GB syndrome, IVIG versus plasmapheresis. So are some sort of like you got a septic shock, skin soft tissue infection patient, antibiotics, neutropenic patient, what antifungal. So toxin injection, what antidote. So that specific aspect you should be aware on that particular case. So one is the general aspect, what you want to tell, and one is the specific aspect particular to that particular patient. So you need to classify your entire thought process before presenting the case under this side heading, so or subheading. So then it is going to be very, very easy. So you can answer immediately with a good rationality. Otherwise, you are going to struggle. Okay. Sorry. So if they ask anything about the nutrition, if you don't have that plan before you present the case, so then you need to like recall, okay, you are going to take too much of time. So it's going to kill your time while presenting the case, particularly for long case. See, things better said than done, okay, but if done, so success is going to be important, means it's going to be sure, and it's going to be success rate is going to be increased. So be confident, presence of mind is very, very important. So think like a consultant and what you regularly do at the bedside. So you are not doing anything wrong during your training period. So some practice may be deviated, but it's not going to be grossly wrong. So never think like an examinee. So even if you get a hit, don't bother. Means you might stuck at some point. It should not kill your the entire process of answering. You need to come out of that quickly. Okay. So questions are generally practical ones, but they expect practical answers with a rationality, theoretical rationality, and with a backup of evidence. That is what they are going to examine. So when you are presenting the case, when it comes to short case, So it will be a system or condition. So they might tell, okay, so percutaneous tracheostomy, or they might tell, so examine hemodynamics of this patient. Okay. So just focus on that only. No need to bother about the entire system examination, because you will get only 15 minutes to take the case and 15 minutes for the discussion. So no need to look at other aspects of the case. So it can be like tracheostomy, nutritional aspect of that particular patient. So or examination of a patient in shock. So it may be related to high flow nasal cannula, NIV, CRRT, arterial line, diastolic dysfunction, so on. So it's going to be narrow down, focus based examination when it comes to short case. That's why you have to be like to the point when they are going to discuss and when they allocate the time for taking the short case. So not to miss any the following points, like examiner might be keenly observing you. Sorry. They will see whether you are greeting a patient or not. Even though patient is unconscious, totally paralyzed on mechanical ventilation, even when patient is encephalopathic, okay, so or hypoactive delirium, or even in brain dead also, it is your duty. You need to greet the patient. Good morning, sir. Okay, so I am Mr. XYZ. I'm going to examine you. I want like a few, I'm going to ask few questions. Please answer relevantly. Like that, you need to greet and explain what you are going to do. Introduce yourself to the patient and to the bedside nurse. That is very, very important. So obtaining consent before examination from patient and staff. So and make sure one female nurse or a female attendant should be there when you are taking history and examining a female patient. Even the sedated patient as well while doing ultrasound and echo in afternoon station, you need to introduce, take a consent appropriately. Even in brain dead, you have to do this, because so you have been allocated that patient. You are going to get an idea patient is brain dead after you examining him. It is your duty to follow all these things without failing, because examiner, even though they are sitting in the corner, they will observe how is your bedside etiquette. Very, very important. So hand hygiene. So use 5 motion hand hygiene. So always when you are examining a patient, always ask for disposable gown and gloves before touching the patient. So main reason when case presentation fail, so these are the following reason. So not enough preparation, not enough knowledge on that particular case, anxiety or nervousness overcomes you, not seen a similar case before, so overconfidence and you like led up with trouble. So language restraints. So these are some of the causes or reasons why you are going to fail in the case presentation. So not enough preparation. So number of cases presented is directly proportional to the status of your preparation. If you never presented any case during your, so like super specialty, DrNB critical care medicine or DM critical care medicine, there is no way you are going to clear it. So in most like super specialty teaching program, it is difficult to find a person who is going to present the case voluntarily. That is a tragedy. So lack of regular super specialty teaching program, that is one again problem. So not exposed to different methodology of examination, like different examiner. So your presentation to only one examiner, so then you are going to get biased. So it is better to get exposed to multiple examiners during your super specialty training itself. So not enough preparation, no schematic protocol you are going to follow. So practice makes you perfect. That is very, very important. So speaking disease, okay. So means speaking disease means you don't have a good confidence to speak in front of public and in front of the examiner. See more number of cases so that you'll get an idea. So what are the things you need to concentrate? Make a habit of writing the case sheet. So that is also very, very important. So that in your long case taking, okay, so you can put the things very quickly in a systematic way if you practice to write the case sheet in a systematic way during your training period. So present to your colleague. So during the training, so don't look at the X-ray first. First get the differential diagnosis, then see for the imaging and all. So think or write your line of management. So all these things, if you practice during your training period, like you need to have your differential diagnosis on the hierarchy basis, and you need to write its management, including how you are going to investigate and what are the things you are going to opt for the therapeutic approach. So speaking disease, this is what it may start night before exam. So fear of presentation, like speaking, fear of examiner and others who are going to present. You might think, okay, what they might think, what your teacher is going to think if you answer in this way. So fear of mistakes, you may get obsessed with the greatest fear of all. So best expressed by Roscoe Drummond. Like, so the mind is a wonderful thing. So it starts working the minute you are born and never stops until you get up to speak in public. So this is the quote. Okay. So basically, when you're supposed to speak in front of public, so your mind is going to have a too much of fear. So that you need to overcome. So how do you deal with it? So anxiety is a natural state that exists anytime we are placed under stress. So examination normally will cause some stress. So don't worry, it is normal. The trick is to make your excess energy work for you. When you learn to make stress work for you, it can be the fuel for a more enthusiastic and dynamic presentation. So that you need to practice during your training period itself. So tips for reducing anxiety: organize yourself. So knowing that your thoughts are well organized will give you more confidence, so which will allow you to focus energy into your presentation. Visualize, practice, breathe easily, focus on relaxing. So release the tension, move. Okay, eye contact with all examiners is very, very important. So that is going to boost your confidence. Okay, so it's going to give a leading edge in terms of like discussion and answering in the examination. Make a habit of writing case sheet. That is very important, as I already told. So writing the inpatient case sheet and cases presented, and keep a time limit when you write a particular case. Okay, and when you are going to have a discussion during your like examination, means during your training period, when you are going to present to your like teacher or a thesis guide or any of your colleague. So if you keep a time limit, that is going to be helpful during your practical examination also. So think or write your line of management. So investigation can be written. So can write management when practicing. So assuming your diagnosis is correct. So in exam, don't write too much. So make your thought process clear. So you have written differential diagnosis, think of the management of those. So like if you have written, so first your DD is pneumonia, next is myocarditis, next is okay pneumothorax, so pulmonary embolism. So you should have a management protocol for all a differential diagnosis in a hierarchy way. That's very, very important. So not enough knowledge, so that nobody is going to help during the examination. So to some extent, directly proportional to the time spent on preparation. If you don't spend too much of time during preparation, so you are going to stuck with the lack of knowledge. Nobody can help if you don't know basics. So sometimes you know, but you forget. So answer is more work. So read about management of every exam case you see in your ward or in your ICU. So not seen a similar case before. So that is one of the problem. So that may create a major problem when you present the case. So suppose, see, couple of my students, they got a patient of tetanus. So they have not seen tetanus during their 3-year tenure. It is very difficult to answer those questions. Okay. So practice a practical problem in some centers. See, some of the ICUs, they have a limited number of patients, particularly in corporate hospitals, or you might not exposed to cases like ECMO or ventricular assist device and all. If you get that kind of case in your exam, so very difficult to answer. So talk to your teacher. Okay. So present some hypothetical cases or case vignettes during your training period. So that's why very, very important. You should have a very good PG or a super specialty training program. So you can attend those kind of training program also, like some workshops or maybe like mock exams. That's also gives some confidence if you have not seen that particular patient. So don't be overconfident. Okay. So should be confident, but not overconfident. So you can stick to your answer if you are sure of what you say. Don't argue. You can discuss with the examiner, but don't go for argument. So unfortunate, but sometimes, so toe the line of examiner. Sometimes you need to accept, okay, so and you need to move on. So anybody can go wrong. So anybody can be wrong. So realize that you are on the other side of the bench. So you are the student, you are presenting to an examiner. Sometimes you need to come to some conclusion. So then you need to move on. So that is very unfortunate, but that is the way you need to, like during the practical examination. So language restraint, so you can ask for translator, should never be a major problem while you are attending a practical examination. It should not or will not matter, because so everywhere you will get some sort of translator or a nursing staff or someone so who will help if you are having a language restraint. Okay. So examiners fault. Sometimes like some examiners, so they might be wrong, but they are not ready to accept it. So they could be wrong. So other examiners will bring it out during discussion. So cannot do it in front of you. So different viewpoint. So always, okay, so you might choose some antibiotic. So they might tell, okay, why not this? So always some different viewpoints will be there. So no uniformity in some topics. Always some gray area will be there. So, but you need to overcome with your good rationality and good evidence-based discussion. So to conclude on the case presentation, steps for winning presentation: quote relevant points from a recent evidence and journal. Okay. So recent studies, RCTs you can quote. So it is going to create an impression. See, in my practical examination, see, I was the alone single candidate, and I was the first DM critical care medicine like person to give a practical exam. So there were around 5 examiners. So from 9 a.m. to 5 p.m. I was the standalone candidate as to answer. See, remember, so each answer I used to quote one or the other evidence, one or the other, so landmark trial. So in the first clinical long case presentation itself only, examiner declared my result. They clearly told, okay, you have passed now. So whatever the remaining we are going to take till evening, it's going to be a formality. So like that, I made my impression with a first long case only, with a good evidence, with a good quoting of like major landmark trials and all. So whatever statement you make, so define your objectives, analyze your audience, means you can gauge so what level of examiner is examining you. So if you get that gauge, so then you can have some sort of leading edge when you are going to answer. So construct your presentation. So only key mantra is practice, practice, practice. Okay, revise, recall. So that is very essential during your training period. So more than what you read, what you have discussed at the bedside, so repeatedly will come to your mind. So this is what I heard from many of my students also. Whatever we discussed at the bedside with the concept, with the evidence, so that they are able to recall when someone asks a question during their exam also. Move on to station. So when it comes to ventilation, so different maneuvers. Okay, so waveforms, not only the superficial ones, you should know all the PV loops and all the scalars. Okay, so like it may be pressure versus time. Okay, so volume versus time. So or like it may be flow versus time. So all these things you should be aware. So in-depth learning of waveform in different modes. So asynchrony, desynchrony, how to identify, how to troubleshoot, identification of mode from the waveform. So that is one way of examining you. So troubleshooting based on the ventilator graphics. So newer modes and what is the evidence for particular newer mode. Maybe it is PRVC, okay, adaptive support ventilation, disease-specific ventilation. So we are going to ventilate a COPD patient, asthma patient, ARDS patient, pneumothorax, so restrictive lung disease, so interstitial lung disease, all those things you should be aware. So need deep reading, rereading, and bedside practice, very, very essential. So reading alone won't help to master ventilator graphics. So you should practice at the bedside and day-to-day practice. Then only you are able to answer thoroughly when it comes to like ventilator graphics and all. So ABG full assessment is needed. Okay, so start with your authentication. Okay, so pH, so respiratory, metabolic, compensated, superimposed. So with differential diagnosis, anion gap, delta gap. Okay, So like urinary anion gap. So all those things are very, very important. So next you should be aware about the treatment aspect. Go systematically. Okay. So don't jump, just tell, okay, it is an high anion gap metabolic acidosis, or maybe just telling like, okay, it is a metabolic acidosis. So don't do that. Go in a systematic way when it comes to ABG. So airway, you should be aware about different causes of normal anion gap metabolic acidosis, low anion gap metabolic acidosis. So osmolar gap, okay, delta gap, all those things you should be able to answer when it comes to ABG. So airway, you should know in and around everything about difficult airway. So definition, so difficult airway society guidelines, newer guidelines, management of difficult airway. So extubation criteria, difficult extubation weaning criteria. So airway, anything on airway, okay. So including airway gadgets like supraglottic airway devices. So different types of laryngoscope, mask, okay. Different airway gadgets, airway, oral airway, nasal airway, all those things you can expect when it's come to station on airway. So you should be thorough on that, okay. Station 2, imaging and investigation, including biochemistry, electrolyte profile, all those things you should be aware. When it comes to imaging, it is CT brain, abdomen, chest. So CT brain may be subarachnoid bleed, okay, ischemic or hemorrhagic infarct, so contusion, hematoma, MRI can be asked. Don't neglect, particularly hypoxic ischemic encephalopathy, stroke, MRI you can get in your station. Ultrasound images, they might ask, okay, so perinephric collection, pyelonephritis, okay, suprapubic collection, subdiaphragmatic collection, those kind of things they can ask in your exam. Chest X-ray, like your post-graduation examination, so they can ask anything, pneumothorax, so or like there might be a foreign body, so collapse, consolidation, pulmonary edema, interstitial pneumonitis. So all those things you should be thorough on chest X-ray. Culture report, biochemistry, they might give a culture report, okay, it is having an XDR, MDR, ESBL. So all those things you should have an idea. Ambler's classification of beta-lactamases, what antibiotic to be chosen, VIVA on like MIC, breakpoint concentration, you should be aware when they give a culture sensitivity report. So can be asked about management of the particular issue. So pancreatitis in imaging is their favorite, okay. So it may be peripancreatic collection, walled off pancreatitis, pseudocyst of the pancreas. You should be like thoroughly able to identify CT of the abdomen. Station 3, like ACLS, if you fail in ACLS, your result, overall result is going to be gone. So ACLS is very, very mandatory for a critical care physician. So they are going to ask about performing ACLS and BLS, different algorithms, bradyarrhythmia, tachyarrhythmia algorithm. So they can go into management of STEMI, stroke, so implantable cardioverter defibrillator, ATLS, post cardiac arrest care, like post ROSC care. So how you are going to assess neurologically. So when you think to start therapeutic hypothermia, what are the contraindication? So when you are going to do 12 lead ECG, so all those things they are going to ask in the post ROSC care. So regarding hemodynamics, so CVP, how to look for the CVP. So they might ask you to freeze on the monitor. So arterial line waveform, dampening, over dampening, under dampening, okay, zeroing, leveling, de-airing, priming, okay. So all those things you can expect. So advanced hemodynamic monitoring like volume, PICO, non-invasive monitoring if they kept like bioimpedance, bioreactance, volume clamp method, like esophageal Doppler, IABP waveform. So you can expect anything on the hemodynamic monitoring. So very, very important to go through all those things. Okay, ECG, another area which needs thorough focus. In-depth knowledge is better than the superficial knowledge. To master it, you have to practice it regularly at the bedside. No other way. So have to go beyond like ST elevation and that of the atrial fibrillation. They might give so like some sort of malignant arrhythmias, or it may be sometimes like atrial ventricular ectopics, or some different toxin-induced ECG changes, digoxin toxicity particularly, okay, QT prolongation, tricyclic antidepressant toxicity, all those things you should be aware when it comes to ECG. So station 4, again, drugs and equipments, they can ask anything, whatever you used during your practice or not used during your practice, okay? So you should be aware about all the antibiotics. So resuscitating drugs, vasoactive drugs, vasodilators, so like sedatives, hypnotics, analgesic agents, okay, everything you should be aware. So this is one of the list which you can keep in mind when it comes to drugs and equipments in your examination. So station 5, so ultrasound and echo. So some centers ask to demonstrate on healthy volunteers. So they might ask you, go for apical 4-chamber view, 5-chamber view, parasternal long axis view, short axis view. So they might ask you to demonstrate a particular view of echocardiography. Some centers kept videos and images, and they might directly go for the like Viva based examination. So basic cues, so lung signs, particularly like uh, whatever like B lines or like your consolidation, collapse, okay. So all those things you should be able to answer when it comes to ultrasound. So they might ask about velocity time integral, E-fast, fast, focus. So even on VEXAS, your examination, like echo examination or ultrasound examination go. So generally, they are not much bothered whether you get a good window or not. So you should be able to attempt all these things. Don't forget to use gloves, introduce yourself, obtain a consent, and wipe off the jelly, okay, whenever you finish your ultrasound examination. So when it comes to last part of your examination, that is Viva, so they are going to ask about the thesis, your topic, how you arrived at the sample size, how you done the hypothesis, okay, what are your limitation of thesis. So like they will find some more extra limitations of your thesis topic. So questions on statistics, terms used in your thesis, questions, any technique used in the literature review. So as I told, they might ask how you calculated the sample size, and they might ask some questions. So whether your thesis interpretation or your thesis result can be used for the practice at the bedside, whether you are going to implement that practice or not. So when it comes to critical appraisal of the paper, so one article will be given. So after the morning session, so during the break, you need to analyze it. Okay. So very difficult after a traumatic morning session. If your morning long case, short case gone wrong in a bad way, then it is very difficult. It's going to disturb you. So just the superficial points you can tell if you are disturbed in the morning. So not expected to analyze as in bottom line or any of the analysis, but assessment of your systematic protocolized approach is going to be very, very important. Okay. So steps to check relevance and validity of a research article. You should put all these questions when they ask about the critical appraisal of paper. So is the study question relevant? Does the study add anything new? So what type of research question is being asked? Was the study design appropriate for the research question? Did the methods address the most important sources of bias? Was the study performed according to original protocol? Does the study test a stated hypothesis? Were the statistical analysis performed correctly? Do the data justify the conclusion? Are there any conflict of interest? Lastly, they will ask, will the results be practicable at your unit? Means, are you going to adopt the result of this particular study? Means, if the trial on Proseva trial, they will ask, are you going to practice like prone ventilation in a moderate to severe ARDS? So then you should answer carefully on any particular like research article. So communication, legal and ethical viva. So how you are going to break a bad news. So violent bystander means like you are explaining patient had unfortunately pneumothorax and had a cardiac arrest. Okay, how you are going to break this bad news and like in front of a violent bystander. They are not accepting. They are trying to abuse you or trying to manhandling you. So you should be prepared for that. You should be having some thought process how you are going to answer all these things. Okay. So medical legal aspects of a medical legal case, toxicology or a trauma patient, you should be aware. So bystander not willing to disconnect even after you are telling apnea test is positive. How you are going to handle that like discussion with that particular patient. So iatrogenic complication, as I told, pneumothorax, or you are telling patient had a nosocomial pneumonia. So relative is not accepting. So how you are going to convince them? One other question they are interested is your bed allocation in terms of the weightage of particular patient. So they will give a scenario like you have single bed available. You have one patient who is 20-year traumatic brain injury with a GCS of 3 and dilated pupil versus 80-year healthy with a community acquired pneumonia on ventilator, whom you are going to prefer and which aspect of the ethics it's going to consider. Okay, so these kind of hypothetical questions they are going to create and they are going to ask during your viva of communication, legal and ethical aspect. Okay, so when it comes to auditing patient safety and quality indicators in ICU, so they will ask you, okay, you are going to start your own ICU. So what quality parameters and infrastructure you are going to have, or you are going to plan when you are going to build an ICU. So quality indicators in ICU like fall rate, needle stick injury, so CRBSI, COTI, CLAPSI, okay. So all these rate, how you are going to calculate, what is the rate in your ICU, what is the benchmark, and readmission, accidental extubation, okay. So bed sore incidents, all those things are the quality indicator. They are interested in how you are going to calculate what is your institute rate and what is the benchmark. Fire safety in ICU, how to do an audit. See, audit cycle you should be aware. Means in the audit cycle, you are going to do some screening. You try to understand what is the existing problem, what is its impact, and you are going to introduce some like process to sort out or to troubleshoot that problem. And once you done some changes, you are going to analyze whether it is changing the problem or it is giving an answer to the problem or not, and you are going to continue the same cycle. That completes the entire audit cycle. They will ask whether you have done any clinical audit other than your thesis. So all those things you should have some thought process while answering. So incident reporting, like someone had some AYA or group D had some sort of accidental exposure to a HIV reactive patient. So how we are going to react means report this incident. So or it may be like one ampule of morphine or fentanyl is missing. So found empty ampule in bathroom. So proceed with a mismatched blood transfusion. So these kind of questions they are going to hypothetically ask when it comes to your viva on audit, patient safety and quality indicators in ICU. You should have some idea before the exam itself how we are going to answer all those things. Okay. So what resources you can use for case presentation? So departmental case discussion, whatever the notes you have made, that is very, very important. So master classes in critical care medicine. So it is our platform. Many success stories in the last 3.5 years happened. They utilize their master classes both for theory and practical. I told again, I am repeating, without your theoretical rationality, concept, evidence, you can't answer practical exam viva. So for ECG, you can refer all these material. So other than that, there are some ASCII questions, particularly for biochemistry. These are not much helpful for your DrNB or DM critical care medicine. So these kind of books you can refer for EDIC part 2 and part 1. So overall suggestions, focus on ventilator, ECG, ethics, quality and communication. Don't keep these things as a fringe topics for last. So you won't get time. Lots of cases and core topics will be there to read. So read, be familiar with examination of system. Time management while taking long case is very, very important. Don't forget about FASTag BD, FASTag in bed, please. That mnemonic you can keep so that you will not miss anything. Structured answer, structured protocolized answering is very, very important. So not the least, do not lose your nerve. Don't be anxious. So that is very, very important in practical viva and station examination and answering. So thank you. All the best.